a place of learning,
a place of discovery, and a place where diverse ideas can be shared in a calm and rational way. Tonight we're talking about something that's very important to all of us, the GP crisis. We have a stellar panel, and I'd just like to say one or two things about that panel before I introduce Ross, who will chair the evening for you. Fiona Van Leeuwen is a practising GP in Newcastle, and she grew up in a small country town in West Gippsland. She trained first of all as a nurse and later as a doctor. And she was a director on the board of the Hunter Division of General Practice, has held numerous clinical advisor roles for the Medicare Local. Fiona is chair of the Hunter General Practitioners Association and is also chair of the Hunter New England Central Coast Primary Health Network's Clinical Council. It's a great privilege to have you here, Fiona. Thank you. Mel Cromedy is a nurse with 27 years experience and postgrad quals in primary care and leadership and in management. And Mel has worked across the tertiary and primary healthcare settings with emergency, intensive care, general practice, aged care. She worked for many years with the Primary Health Network as a team leader and primary care practice support. And she's now a facility manager for Calvary Retirement Communities located in Maitland. So welcome, Mel. Michelle Redford grew up in Windsor, UK, and studied at the University of Newcastle, but not the one here. Newcastle upon Tyne in the UK, and she lived and worked in and around Newcastle, UK for many years. She's interested in all areas of medicine, initially training in hospital medicine and gastroenterology before moving to general practice in 2004. Michelle is also a GP advisor to the Hunter New England Central Coast Primary Health Network in integrated care and practice improvement. So welcome, Michelle. Nigel Lyons has over 30 years experience in the New South Wales health system as a clinician, manager and executive. He graduated with a Bachelor of Medicine with honours from the University of Newcastle. Nigel is now a special advisor to the New South Wales Ministry of Health. He's responsible for strategic health policy development, interjurisdictional negotiations and funding strategies, system-wide planning of health services, including mental health, and setting the direction for child and family health policy. He's held a number of board appointments relating to these areas throughout his career, and it's a privilege to have you with us here, Nigel. Ross Kerridge. Now, many of you may not realise this, but Ross was one of the founders of the Newcastle Institute in 2004. And apart from being a senior staff anaesthetist at John Hunter Hospital, and where he also teaches training specialists and medical students, and in his role as an associate professor at the University of Newcastle. But Ross has a very broad and interesting career, and he writes... And Ross has very diverse interests, and I recently went on a historical walking tour of Newcastle conducted by Ross, which I thought was just fantastic. You may have read some of his articles in the paper recently, ranging from issues like the GP crisis through to other matters of public policy. And one that created got a lot of attention was an article that Ross recently wrote about our community swimming pools. So he's a man of diverse interest, and it's a great working with you, Ross, and thank you so much for chairing tonight's discussion. Would you please welcome all these people to this? Right, thank you. I don't know, hang on. What do we... Sorry? No?
I don't know.
It's okay now? Yep. All right. Yep. So now I'm on, but my job at this point is just to say, so the format of the night, I'm trying to be Tony Jones with a panel. I'm showing my age now, I don't. It's what David Spears or, I'm facilitating the discussion. But what we're going to do is Fiona, will speak in her own right, but as we've heard, is president of the local General Practitioners Association, is going to give a sort of short presentation on her perspective on where we are, why we're talking about the GP crisis. And then Nigel Lyons, and Rob undersold Nigel, I think. Nigel has been CEO of Hunter New England Health in the past, and then went on and has had a number of very senior roles at state level, and has recently been involved in the strengthening the Medicare task force, which I'm sure he'll talk about, and is now guru advising the ministry and whatever at state level. So it's great to have Nigel in town, and it's been great working with Nigel in the past. But so Nigel's going to also do a short presentation, if you like, from the upper echelons on his view and about what's going on with the GP crisis. And then we're going to have a panel discussion with the four of them, and that will lead into questions from the audience as well. So somewhat modelled on Q&A. I'm not Tony Jones, I know I'm not nearly as handsome. So Fiona.
You've got rid of all the gremlins. Thank you so much for inviting me along, and indeed it's an absolute pleasure and honour to be here with you this evening to discuss what I think is a really concerning issue, and we call it, I guess, the GP crisis. Something the likes of which we've never seen. I've certainly never seen in my lifetime or in my working life, and perhaps some of you in the audience have seen different models of care prior to my time. And I think this evening we're very fortunate to have a number of people here who are experienced in different areas of healthcare, so hopefully we'll get a really vibrant discussion. I just wanted to say that I also want to acknowledge the local Indigenous people on whose land we meet today, the Awabakal people, and any Indigenous people amongst us here this evening and out in the audience who may be watching the later recording. I find the current truth-telling such an exciting way to provide healing and a way forward for the current Australian population. I just wanted to mention what's a crisis. I was thinking, how do we give this talk some kind of interest, and how do we make it fun and interesting? I guess a crisis might be called a time of great danger, difficulty or doubt, where problems must be solved or important decisions made, and I think that's what this crisis is. I'll get round to what the crisis is in a moment. I just wanted to divide, I guess, the crisis into a few areas and provide a little bit of historical perspective on how I think those areas have come to perhaps fail us in the current context and why we're struggling with them so much. One of the really relevant components, of course, of healthcare is the structures that provide the underpinning funding for healthcare. And because we're a federated nation and we have states, we have health funding that goes into the state that's delivered by the state governments, and we have health funding delivered by the federal government. Generally speaking, the federal government funds primary care, general practice, most things that happen outside of hospitals, and the state governments, as you know, fund a lot of most and pretty much all of what happens within hospital systems. And it's an intriguing situation to be in, because really patients flow through the primary care sector and then also into the tertiary care sector, funded by those different bodies, and then also have been encouraged more recently, I suppose, to join private health insurance funds. So the third arm of all of that really is the private sector, which is private hospitals, private specialists in their rooms, private allied health providers. So as a GP, we do get a bit of a bird's eye view of patients navigating all these things, and ultimately I always think it's our responsibility. Sorry, that's doing an odd thing. I always think it's our responsibility to try and help people as patients to navigate the health system to get the best healthcare that they can afford. And it does vary immensely amongst people. So I guess a little bit about the history of Medicare. Medicare came around sort of in the mid-80s, and the idea of it, I think the general notion was, free healthcare for all, which we'd all like to have, but that is getting harder and harder to come by. And what's happened is that Medicare is sort of designed by having been given a whole bunch of item numbers for being different descriptors for service points. If we're doing an ECG, for taking out someone's gallbladder, for spending 6 minutes with a person or 6 to 20 minutes with a person, and each of those things, the government decides what the Medicare rebate to fund patient engagement in those things will be. And initially, I think it's probably fair to say that the Medicare rebates were pretty reasonable and pretty much covered a lot of the costs then. Subsequent to that time, costs have increased, and there's been some issues around Medicare not keeping up, and so people are paying more and more out of their own pocket for services that they receive. So that's one of the intriguing things, I guess, about Medicare. At the moment, in general practice, we can't do the care we really want and need to do and design under the current funding structures. You might wonder why, when you go to the GP might rush off to see the nurse every now and again and then come back to their room, and they sort of rush into the door and go, "Hi, yeah, good to see you having a flu shot. Great. Lovely, pop back into my room again." But I have to do that because if I don't do that, under the Medicare rules, if I don't visit upon the patient, I can't bill the item number for that service. So it means that the nurses actually, we can't get any funding for the nurses unless the doctors do that. But of course that's a bit of a waste of doctors' time when we feel that nurses can be highly trained and function as fairly autonomous members in our group if we all work together. So there's some of those things that kind of cause these structural barriers, and then we all spend our time ducking and weaving to pull it together to make it work and hopefully pull out of Medicare the most funding for the patient that we can get our hands on at the time. Medicare has an interesting, some really interesting historical components too, and I suspect that when Medicare first came about, people used to think that surgical things were really pretty amazing. And they are amazing, they can be life-changing, can't they, for people, surgical operations and things like that. And so they are, generally speaking, pretty well funded under the Medicare system. But what's happened over time is that the medical non-surgical medicine has become so much more complex and so much more useful to people and so much more frequently utilised. But it still relies on the lower fee schedules under the Medicare items. So it might be actually more beneficial for somebody to take off some skin lesions from a person, which is pretty easy and fun and doesn't take very long. And you might actually get paid more for doing that than if you care for somebody who has diabetes, heart failure, a recent heart attack, and pulmonary embolism, and is struggling to live on their own home with very few supports. So there's these sort of structural anomalies with Medicare that make it difficult, and we're struggling with all of those things. But we do our best to manage them, and we are very fortunate in this country to have Medicare because it enables people to get funds to help them to access medical care. It's not all out of your own pocket, and so that's a good thing. The other thing I've just briefly alluded to, I guess, the second part, so the structural components and the history of Medicare. The second part really, I guess, in terms of this GP crisis and the genesis of this GP crisis is the clinical changes that have occurred over time. So I was briefly mentioning, the burgeoning of medical care for people, non-surgical care using medicines. That also involves lots more investigation of people, and we have now got MRI machines. Actually, when I started in medicine, there was no MRI machine. We had a CAT scan, we thought, which was pretty cool, but no MRI. So we have all kinds of other investigative tools now that we can use. And that means that we can find more things and do more things and prevent more things and, so it's got much more complex. Back in the day, I guess you used to go to the GP if you had an issue, you had a sore knee or chest pain or something, and then the GP would address that particular issue. But these days when you go to the GP, what we are spending our time doing is seeing you with a sore knee, but then we might check your blood pressure because we actually really care that we're trying to reduce your cardiovascular risk of having a heart attack and a stroke. I know they're there for your knee, but by the way, how many COVID vaccines have you had? And let's just jab you with COVID and the flu shot at the same time while you're here with your knee. I'll quickly look at that and we'll do the X-ray. So general practice has, and primary care has become much more engaged in managing acute care for people. And we do all kinds of things. You wouldn't believe what walks through the door. It's like fascinating. It's incredible. So it is a great job, really. And then we also do lots of chronic disease management. So now we manage diabetes really proactively because we want people to have good quality of lives, live as long as they can, as well as they can, prevent heart attacks, strokes, all those things. And then we do a lot of this preventive care, as I alluded to, with vaccinations, cervical screening tests, making sure people are having mammograms, their bone density, checking in on prostatic symptoms, skin checks, those sorts of things. So general practice over the course of the last 20 years or so has actually changed a lot. And it's been really hard, I think, for our medical system to keep up with that, with the funding systems and the way that we all interact together to keep up with that. The third area I want to talk about really was workforce with regards to this crisis. Because I guess, the GP crisis, I think about 50 to 60% of graduates, maybe 20 years ago or so, used to want to be GPs when they finished their training. So everybody goes to medical school, and then you go into the hospital and you do 1 or 2 years in the hospital. You might be a registrar for another year or two, and then you decide on specialty. So then you might do general practice training. So GPs are trained as specialist general practitioners, and cardiologist does general physician training and then becomes a heart specialist, for example. So there's less and less people now who want to do that. That's one of the problems, one of the reasons we're having less GPs and not enough GPs to care for our patients, why we don't have enough GPs. Secondly, I guess, general practice, because of all the red tape, has become really complex and quite frustrating at the best of times. So it's not always very attractive and very appealing for these young people to come into general practice, even though it's the most fascinating thing ever. You'll see a 2-week-old baby, a pregnant woman, a 2-week-old baby, and then a 95-year-old person, all in the space of probably 25 or 30 minutes. That is pretty amazing. So generally speaking, I find the GPs that are absolutely inspiring. They work fast and they work at every level, and they will try and give you the best care they can if you give them a chance, So with regards to workforce, I guess the other thing is it's a busy and hectic job, and you do have to be on your game all the time. And this is a bit off-putting if young people are feeling that it's so intense and they aren't able to, receive the remuneration and conditions that they would hope for in a professional life that is equal of all of their medical colleagues in other specialties. So I think it's reasonable for a professional person to hope to get some support around their own ongoing education, meeting with colleagues to discuss how systems work, maybe going to the old conference, certainly having some protected paid time to improve practices. If we don't see a patient in front of us, there's no pay for us. So if someone doesn't show up, there's no pay. If we're sick, we go home and there's no pay. We fund our own education, so we go to things and then we pay for that ourselves. And all of that probably was much more manageable when the Medicare rebates were better. But they haven't really kept up, which is why GPs have started, I guess, in primary care to charge these gaps for people. GPs have, for some very strange reason, but I think it's a good thing, always supported people who they thought couldn't pay as much. So if somebody's on a pension or a healthcare card, then GPs have always, out of their own pockets, if you like, because individual GPs are paid a percentage of what they bring through the door for Medicare, charge $75 for a person on a pension and $95 for a person who can pay. But I sell you the same pair of jeans. Exactly the same pair of jeans. I'll turn myself inside out for you. I don't really care if you pay, don't pay, whatever. I just want to do the best I can for you. these are the reasons, I guess, we're having a GP crisis and people aren't so keen on joining general practice. The other problem with regards to workforce is that we know that practice nurses would be fabulous, but we can't find any because there aren't any. There are hardly any that are trained. There's no general practice and primary care training in hospitals. So I don't know that nurses know that much about primary care work. I think we need the best and the brightest to be there because we cover everything, from gynecology to cardiology to skincare, absolutely everything, just do everything. Can't have a person walk in and go, I've got a thing on my nose, guys, sorry, I don't do noses. So I guess the things we're looking for is real health system change and reform, and we really like people to step up and be courageous and work hand in hand, with the tertiary care sector, and just engage so that we really support the whole of the patient care journey. So back to the crisis, it's a time of great danger, difficulty or doubt, where problems must be solved or important decisions made. And I think we need to solve these problems together. And I think people as patients need to stand up, please, and help us do this together. One of my really clever and best friends said to me, there's three things, there's three human rights, Fiona, that must never be politicised. So I guess this is a separate kind of issue in a way. But and I said, yeah, what are those things? And she said, well, she's an education person, so education. I thought she'd say, the other one was housing, and then the other one perhaps was health. So at this time of great danger, difficulty or doubt, where problems must be solved and important decisions made, I'd like to invite you to ask us some really tricky questions. We're all ready and have a really good discussion this evening. We'd like to hear what you think too. Thank you so much.
So, thank you. And we'll just go straight on with Nigel and then we'll have a discussion. Yep. I'm jotting down some curly questions to throw at you.
Thanks very much, I am very pleased to be with you this evening to have this conversation and to provide a different perspective, probably from the point of view mostly of the state system and the impacts on the state system of what the challenges that Fiona's outlined are actually impacting in terms of care delivery and the services that we provide. Before I start, though, I would like to acknowledge traditional owners of the land we're meeting on tonight, and I'd like to pay my respects to elders past and present, and in particular to any Aboriginal people who might be here this evening. So we have a particular challenge at the moment. I think we always should come back, though, and acknowledge that we do have a very good health system in this country overall. And while we have our challenges at the moment, I continually thank my lucky stars that I'm actually in Australia and have the system that we have. And you can compare what is happening around the world in terms of access to healthcare. We should be very grateful for what we have. The Medicare system has served us very well, the components that Fiona's outlined, but in particular I want to acknowledge the Pharmaceutical Benefits Scheme, an amazing scheme that allows us to access medicines at such a reduced rate, medicines that most other people around the world pay huge amounts of money for. I mean, I think the antivirals recently for COVID were about $1,000 a course. And we were paying $30 or $7 depending on your circumstances for access to that course of oral antivirals. That's an example of the benefits of the Pharmaceutical Benefits Scheme. Look, we have got big challenges at the moment. I mean, we've just come through COVID. The pandemic response was amazing, but it took its toll on everybody. And in particular, I want to acknowledge the huge amount of work that general practice did in responding at a time of particular challenge. We asked a lot of our general practitioners, taking on all the other things that they had to do, changing the way they delivered care, providing access to immunisations and all the other things that were done. The health system did respond amazingly, but I think what's happened is we've come out of the other side of it. We're starting to see a whole range of issues that were bubbling away underneath really become very prominent. And that's happened very rapidly, which is why I think we're in the situation we're in now. There's no doubt we see on the state side that a lack of access to primary care has a whole lot of flow-ons. The major one, of course, is that not being able to access primary care either because of cost or because of the time frame to get to a GP appointment. Sometimes we hear 2 or 3 weeks. In some parts of our state, there are communities that don't have a GP resident in the town at all, so access means travelling hundreds of kilometres to see a primary care doctor. So those things then lead to people not accessing the care that they need, and in particular might get to a point where they have an acute on chronic condition, or because they don't know where else to go, they turn up to our emergency departments. We've seen an inexorable increase in ED attendances across the state. We're now back above the levels that we saw prior to the pandemic, and what's changing is we're actually seeing patients who are more acutely unwell. So the people who are attending our emergency departments are those ones who actually are in the higher acuity category, as we call acuity categories, those people who need access to care more quickly because the illnesses they have are actually more life-threatening. So those are concerns that we have about access to care, and we think good primary care would be a very good way to address those changes. But the other thing we're seeing is because of out-of-pocket costs, particularly for secondary and specialist care, we're also seeing a massive increase in referrals to our outpatient clinics, to the point where there are long waits across the state for many of our specialist outpatient services, because most of those in our hospitals are free at the point of care. So there are huge issues for us, and we need to start to get those issues changed. How do we get here? And I think Fiona's talked about some of it, but I think we need to acknowledge that medicine has become very specialised, highly specialised, and that's a good thing, because it allows us to have access to people who have huge knowledge, very deep knowledge, very specialist knowledge, and can provide care that was previously not available at all. And we're very fortunate in Newcastle to have access to some of the best specialties and subspecialties that you would find anywhere in the country. We've got access to neurointerventional stroke care. We've got access to interventional cardiologists, to laparoscopic surgeons, neurosurgeons, heart surgeons. So we've got access to all of that care. But when I first started to train, we used to have general rosters for general medicine, and we used to have general rosters for general surgery. Now we have rosters for hand surgery as a component of orthopaedic surgery. We have a trauma service which is separate to the rest of the orthopaedic service. So what's happened is we've got all of these specialists who've got knowledge and expertise, which we want them to have. We want to have those services, but they then have a lot of doctors needing to be recruited to that service to enable it to be sustained, to be able to have rosters that run, to have the workforce that's available to provide that in an ongoing way. So it's sucked up a lot of the people who come out of university into these specialty and subspecialty areas. And because the knowledge that is required in those is very deep, the people who do general work actually have to have extraordinary knowledge across almost everything. And that's a huge issue for people who used to practice general medicine and used to practice general surgery. And in fact, even the medical insurance side of things has driven that change, because some of the factors that people are held to account for if they provide care to a patient, they're held to the standard of somebody who is equivalent or has equivalent specialist knowledge in that area. So if you're a general person providing care and you're actually held to account for the level of specialist knowledge, it's very difficult to defend decisions you do or don't make if you're being held up and held against somebody who might have that specialist knowledge. So we've seen a move away from generalists and much more specialised care. And that's led to, I think, the training in our hospitals where our young doctors, and Fiona alluded to this as well, they're exposed to those specialties, those subspecialties. They see people who work in those areas. They don't get exposed to general practice as part of their rotations as junior doctors. The only time they get exposed to general practice is if they choose to have general practice as their career, and then they go out and do their training outside of the hospital system in general practice. And the other factor that's driving people, we're hearing from people who are going into general practice, changing the way people think about doing that, is that they're actually unemployed under an arrangement in the hospital for all the other specialties that train. You're actually employed as a registrar, which means that you're employed, you get access to leave, you get extra holidays, you get ongoing employment arrangements and accrue entitlements and leave and things. If you go into a general practice training, you've actually got to go and negotiate a contract with each of the GP practices you work in, which means that how you get remunerated is not necessarily the same, and there's no continuity, and you don't get access to those sick leave and other entitlements necessarily that accrue. Didn't you know that? Well, there you go. So that's why I'm talking about it, because that's why it's a major barrier for people to going into it. So we We are very keen to see these things change, and at the state level we are actually having discussions with the Commonwealth about how we start to reorient these things. We need to, I think the other thing is value general practice much more than we currently do. Fiona alluded to the differential in the fee-for-service and the MBS rebates between specialist practice and procedural specialist practice and general practice. It is necessary for us to start to think about how we manage chronic diseases more effectively, because that means more time with the patient, explaining things, supporting them and their families to look after their health in different ways. That's not remunerated well under the current arrangements. So we're keen to see a real shift in the focus around how GPs are remunerated, moving away from fee-for-service as the primary driver of remuneration. We need to move to different arrangements for training. In fact, the state is now starting to step in and say, well, why don't we start to create opportunities for GPs who want to train to be registrars, employed by the state and rotated through general practices and maintain entitlements and a certain level of remuneration while they do that, to encourage them to do it. We need to give our junior doctors more exposure to general practice in those first couple of years after they graduate, so they can actually see what it's like to work in general practice, and they might be excited and enthused to think about that as a career option rather than the hospital-based specialties. We also need to value at the system level. I've worked in the system for 30 years, right from the time I worked clinically. There hasn't been a strong value in general practice from the hospital side. Specialty care is seen as better care sometimes, and I think what we've got to say is we don't believe it's necessarily better care. It's got a very important place, but general practice care and primary care is very important care, and we need to support that as well. Our whole system is oriented to move people into specialist care, referred by GPs. How many times have you heard people talk about, I'm just a GP, not a specialist? So there's this sense that people may be not as valued by the system if they're not a specialist. We've got to start to reorient that and say that the care that's provided by generalists is really important care. We've got to support that. We're at the point now in some of our hospitals where, because everyone's so specialised, if you come in with a couple of chronic conditions, you might have 6 different teams looking after you because of the specialty knowledge in each of those teams, and Ross would know this full well. And that is fragmenting care and not necessarily providing the best care for our patients. So we've got to get more generalist organised care and certainly provide that in our hospital space. The other thing we've got to do, and I'll quickly wrap up because I'm conscious of time, we've got to invest in systems that link the care much more effectively. The care that's provided in hospitals and the IT systems that support that, and the systems that capture information in general practice and primary care don't talk to each other well. There's no linkage, and many people are surprised to know that. We're starting to make steps towards linking with pharmacies and having digital prescriptions and information that's provided directly there, but there's so much more that's got to be done in linking the systems between the hospitals and what goes on in outside of hospital space. And the state is very committed to doing that. I think the Commonwealth has been committed to My Health Record, but we don't think at the moment the My Health Record is delivering what it needs to do to actually provide that information in a way that's useful for people. So those are the sorts of things that we need to see changed. We're certainly investing in getting that integration. We're working with the primary health networks, which are the networks that support general practice across the state. We have an agreement with them at the state level that we want to have a mindset together which is about having one system. And what we collectively do is need to drive the system to that end and think about what it means for patients to be able to access care. And the state's got to get, I think, much more involved in supporting what goes on in the out-of-hospital space than we've historically done. And the state is willing to do that, but we want to see how the Commonwealth supports that happening too. Which is why I think the announcements in the most recent federal budget around strengthening Medicare are actually a good direction. They're in line and in consistency with the recommendations that came out of the Strengthening Medicare Task Force. That task force said that we've got to get a better relationship between patients and general practice, so this concept of voluntary patient registration and linking a patient to a practice and establishing an ongoing relationship is an important one. We talked about needing to establish support for multidisciplinary care, so that the things that Fiona talked about, which is, if there's a practice nurse not being able to bill unless the GP sees the patient as well, we need a different way to support the payment of those staff in the general practice so that the GP doesn't need to do that. That there can be an agreement about who does what in the team without actually having to have the GP see the patient every time. We need support for better information systems to be collecting data. We need to have arrangements in place to support the time that GPs actually spend in non-face-to-face care. That's important work too that needs to be recognised and remunerated. So these things were outlined, and I think the directions that were announced in the budget are a very important step towards that, but we would argue that a lot more needs to be done over time, so very pleased to see those initial investments. So I think there is potential for change. A few of the things I've outlined are the sort of things we're thinking about doing differently, but there's a lot more that needs to be done. Very happy to hear the conversations that unravels tonight. Thank you.
Organised. Just before we start, some of you may have noticed my shock at that revelation about GP trainees. And part of the reason is some of you all have noted that I'm a anaesthetist, but in fact I'm a failed GP. I did start off, and back in the 70s, when I went to medical school to Sydney, we were being told all the time about the GPs are the bedrock of the health system, that's what we need, and we were given a whole lot of role models, very efficient, and there were a whole lot of the gods of general practice being, it was a deliberate thing, but we were being given the message of how important these people were, and shown role models, and I thought, yep, that's what I want to be. And I signed up for a thing called the Family Medicine Program, and my understanding of it was that, and certainly for me as a junior doctor, it was entirely seamless. I didn't realise that it changed that much, because essentially, on Friday I finished in whatever job I'd been doing, and then on the Monday I started with my general practice attachment at Mooloolaba, and the pay was exactly the same, and I don't know, no one wants to do it. So I'm not sure when that happened, the 70s was a long time ago. Anyway, so we've heard about the problems in Australia. Michelle, you worked in general practice in Britain, and I know from our prior discussion that you said it was great working there. What was it like? What was different there when you were working in general practice about the way it was structured? Because I know a lot of people in Australia think, or in the medical world, we're taught that the NHS is a mess and all this sort of thing. I must have died in 3 years of my specialist training, my anaesthetics training there. Not at all. Both personally and professionally. But what was it like as a general practitioner working in England?
Yeah, thanks, Ross. Well, you may not have been through a GP crisis before, but I certainly have. So that's the reason I'm here. This is quite echoey, or is it okay? I wouldn't be in Australia if I hadn't already survived one GP crisis, and that was in England, where I had been a GP for 10 years, and I saw, a thing of beauty that was UK general practice be systematically destroyed. And the job that I went into as a plan for the rest of my working life was not sustainable. It became just completely untenable, and I was lucky enough to be able to jump ship and did my research into those kind of healthcare systems where I might be able to thrive and survive, and here I am. I've been here for 9 years. I consider myself very fortunate to have had a second option. But the reason that I'm here, and the reason I'm grateful to be invited to be here, is because I'm now passionate that we actually use this crisis. Never waste a good crisis, isn't that what we're told? With every crisis comes opportunity, so that we don't follow the UK off the cliff, because I've seen it happen. And I'm only 25 years into my doctoring, and I've always fully intended to go a good 40 to 50 years. And I don't want to see this thing of beauty that we have here destroyed in the same way.
So
explain what went wrong.
yeah,
Yeah, so in the UK you have capitation, but more than that, so capitation is where you get paid. So in the UK you have registration of patients on a practice list, which is determined by geography, and patients have, well, now they have a bit more choice, but back when I was there they had very little choice of which GP. And then for each patient on your practice list you would get a sum of money per year, probably around the £100 mark, so $180, something like that. And for that sum of money you had to provide all the primary care services that person required. And you might employ a practice nurse, you might employ a dietitian, various other people, but it's also run on a small business model where the GPs generally as partners took on all the financial and business risk. So actually that part not dissimilar to the model that we have here. The difficulties, in my opinion, started in 2004 with the imposition of it. Well, actually, bargaining when you contract, where nationally, as a GP, every GP practice has a contract with the government, and it's nationally imposed, and so it's that or nothing. There's no private care that you can provide for your patients. So year on year, there was more demand on general practice, more quotas to reach, more hoops to jump through, more work to do, and no money to follow it. So some of the things that we're seeing here started to happen. So when I applied for general practice, it was a competitive process. There were more applicants than places. Here, we've gone from 50% to less than 15% of medical graduates wanting to do general practice. So we started to have places empty on our training schemes. We struggled to recruit anybody from anywhere. We had trouble recruiting reception and nursing staff because no one wanted to work in general practice. And so lots of this, and people were becoming increasingly dissatisfied. We're seeing more violence in general practice. So we're starting to see lots of those same trends here.
Yep. So, and when I was a trainee in England in the 80s, I did respiratory medicine for 6 months. And I must admit, it used to amaze me. This is in East London. We would do a ward round on a Monday afternoon, and patients who were getting over an exacerbation of their chest illness, at 4:30, 5 o'clock on a Monday afternoon, and would say, yeah, okay, you can go home tomorrow morning, and say, yeah, okay, we've got to start organising this, and nurses on the round say, yeah, tick, tick, boom, boom. And literally, 9 o'clock the next morning, they would be sent home, and they would be met at their door by the district nursing service, and it worked. I thought, how is this possible that this works? But it was all
it used to work, but years of not funding it, most of it's correct.
So you were funded with capitation, which means that I sign up with you and you get a bit of money for looking after me for the year.
The practice does.
Or the practice does. But when I come in to see you, do you get some more money on top of that? Or?
No, you can come every day. There is no more money coming. There was some extra money for meeting certain targets, like if all of the people who had diagnosed with diabetes had their blood pressure control target and stuff. So for that amount of money, you had to work harder for it each year. So it's not that the money went up. You had to do more and more for it each year.
So from a business point of view, you don't want to see the patient at all.
No, so when I came here, I found it actually really difficult to adapt because my model of general practice was to do everything you could possibly do right here, right now, and try to never see them again. Because it's terrible, but and I adapted very quickly. But that was how it had to be because you just didn't have the capacity. There were no more doctors to come and help. There was no more money. And so you had to somehow try and restrict demand. I don't think we need to use the UK example as something to follow, but it's certainly something that we can learn from. And I think what my colleagues were saying, what Nigel was saying about general practice being so critical for the whole healthcare system and historically having been undervalued, now is our chance to explain to people our value proposition, that if you have continuity of care with a general practitioner who is actually a master of managing uncertainty and continuity and the context of an individual person within their environment and their social construct, then you live longer and you don't go to hospital as much and you cost the government less and you don't need to see non-GP specialists as often. And all of those things are really good outcomes, and it's the cheapest way of achieving them, by investing in primary care.
I was going to say, from my point of view in hospitals, my experience, when we've got someone lining up for complex surgery, the number of times they've been seen, or I've seen them, or a registrar's seen them, or whatever, and they've got these problems to be sorted out before it would be safe to do surgery. And being an old Newcastle person, I'll say, who's their GP? And they mention their GP and say, great, it's fine. Or they don't have a GP, they go to the rapid turnover centres and just think, oh no, we're on our own. And it's going to take weeks to get this patient ready, and we're going to have to do all the work, and it's going to be very expensive because we do it pretty inefficiently. You didn't hear me say that, Nigel. So, Mel, how do you see the nurses contributing to fixing the crisis?
Yeah, great. Thank you. I'm really excited. I'm going to try and curve it right down. Very excited, and probably one of my opening communication lines, with now working in aged care, to the hospital. I don't get it from general practice, I will just put it out there. Sometimes I do have to say, can you please stop speaking to me like that, because I work here, because I choose to work here. I choose nursing as my profession. Perhaps I could have been a doctor, I could have been a specialist, maybe I could have been an architect, I don't know, but I chose nursing because I'm passionate about it. I'm passionate also about the impact we can make to improve primary health care outcomes. I find that nursing gets lots of rewards and lots of accolades if you work in the tertiary sector, because you are part of that amazing team with, X-ray right at your fingertips and the MRI machines and everything else. But, in general practice and in aged care, working in the community, it's just us, it's just our eyes, and we want to make sure we're doing thorough assessments, and we have to know the anatomy inside and out, so that we're communicating with the professionals, our GPs that we're working with, to know exactly what we're reporting through is true and accurate to how we can assess at that point in time. So we're a valuable asset to the primary health care and the outcomes. I think that I've had the privilege of working with Fiona many years ago in introducing new models of care and how nurses can change the flow through a practice, looking at, we do chronic disease management really well. If I had $1 for every time a patient would say to me, I'd say, why didn't you tell the doctor that? Oh, they've got no time. But they'll tell you absolutely everything, and can really get in behind what's going on for a person, take less time from our GP and actually coordinate and plan, great care for the person, which works. The thing is, there's no funding for that. So with respect, I can be a registered nurse working in the tertiary sector and probably bring home way more money than I do managing a nursing home. But there's no funding. There's no funding for, when I worked in general practice, I couldn't match a pay rate to my colleagues who still worked in the tertiary sector. And what I did was just as important as what they did, working in the ED or the ICU. But my GP owner, or who I worked for, no way could match that pay rate. And there was never ever a question that I didn't bring value to the practice or to the people I was caring for. It was just the system wasn't there to support it. So I think models of care, there's been hundreds tried and tested that work, that do get better outcomes for our patients, or our are we calling them patients in the community? People. But again, it's the funding. When you talk about nursing, it's about retention or attraction and retention. Before I finish my career, I'll probably stay in aged care, but before I finish my career, I want to make primary healthcare sexy again. You know, we don't get students. We don't get students from the universities because we're not funded. We don't get students. I don't get. So we have all of these graduate nurses that finish their degrees that leave this amazing area because they don't get a postgrad. Why isn't there funding? I can't get registered nurses. If you're growing them somewhere, that would be really good. You know, but if we're letting all of these new grads leave because they've, we've got no postgrad positions, why aren't we putting them through general practice and into aged care where we're screaming for the workforce and we're letting them leave? I do just want to do, not really a plug, Lily's a little plug, but the Australian Practice Nurses Association, APNA, sorry, that's a big thing to get out. We're doing amazing work in that space, and thank you, compliments need to go to the Commonwealth, who are funding transition to practice positions. So they've been working, I've got all the stats here if you want to talk later. The number of nurses we're putting through transition to practice working in general practice. So there's been 1,500 applicants just this year. We're also transitioning now to do a pilot for transition to practice into aged care. So that's also going with trained nurses, but also undergraduates. So looking at showing and showcasing primary healthcare as an option for our undergraduate nurses, which never happened. It's usually they'll have a spot in mental health, general medical surgical perhaps, paediatrics, very rarely aged care, and certainly not general practice. And again, that is also coming down to funding as well.
You can keep the microphone for a little while, but this question is for all of you, because you've been talking about practice nurses, and the way you've been talking has been very much as part of a team and working in a group general practice, I think, or in aged care. But a lot of the discussion about the problem of GPs, particularly in rural and regional centres, one of the solutions has been nurse practitioners, which I think is a different concept again. I'd just like to know what you're feeling, and you can say your feeling or the Practice Nurse Association if you want to, whatever. And Nigel, is this something at the state level? Do you see this as a solution, particularly for rural and regional centres where there's no GP, or elsewhere, or even in regional centres like Newcastle?
So they're amazing. They certainly have their place, but we also don't have enough of them. And for rural and remote health, absolutely. There is certainly a place. So they have a different level of training. So they do have prescribing rights for some medications. But I don't really think that that's so much the answer. So nurse practitioners for rural and remote health, absolutely. Definitely couldn't work, I guess, around here in the urban centres as well. But where do we find them? And how do we incorporate that model of care for the support to keep going and fund them as well?
Yeah. Well, I think I can't remember who it was, but some economist guru 4 or 5 years ago was saying this is a solution for city general practice as well, and all this. So, but
Can I make a comment? Just a brief comment on that. Keith Drinkwater from Hunter Primary Care. We've been very fortunate recently to have embarked on a trial partly funded by the Primary Health Network and ourselves in collaboration with some aged care facilities across the region,
in trialling just that, nurse practitioners working in collaboration with local GPs in support of 5 practices. And I think I might have spotted one of my former colleagues here who's operating one of those aged care facilities and 5 control groups. So we're really hopeful that that will turn to be, or prove to be, an effective solution that potentially would be self-funding at the end of the trial. And the University of Newcastle, or the Newcastle University, is supporting us in evaluating that service. So it's a good news story locally.
Nigel. Yep.
Well, I think nurse practitioners are part of the solution, there's no doubt about that, and I think we need to do more in terms of supporting nurse practitioners and thinking about their role, particularly in places where we are struggling to have other providers available and we want to have advanced care provided in those settings. So I think we're thinking about that in rural and regional settings, but it needs to be done as a component of the solution. I think we can't look at any one thing being the golden bullet. It's got to be a range of things that we put in place that will actually address the issue, and nurse practitioners are certainly part of the picture.
Just a simple question. I've come across prescribers in England. Is that the same as a nurse practitioner? A prescriber?
Yeah, we did have nurse prescribers in England similar. Yeah.
And are we likely to get them here?
So we do have nurse practitioners, we just don't, who can prescribe from a limited formulary. So very similar to the model that they've had in the UK for a number of years.
Thank you.
Just by way of explanation, I don't know if everybody already knows, but so there's lots of different nurse training things that are around, or for people that do some kind of nursing services. You can be an assistant in nursing. Does the enrolled nurse position still exist, or is that? Yes, you can be an enrolled nurse. You used to be able to be an extended kind of enrolled nurse who do extra stuff. Yes, still that. And then you can be a registered nurse. You can be a nurse practitioner. And a nurse practitioner is somebody who actually practices independently. Okay? So nurse practitioners are really helpful if you're in a place where there's no doctors, and the nurse practitioner will see you with your broken leg, your sprained ankle, whatever, and they'll work out what to do, and they may get some support and help from doctors, remotely or whatever. The problem is we haven't really been able to find a funding mechanism in urban general practice for those nurse practitioners. Personally, I guess my view is that I think we can use all kinds of nurses in general practice. I think we need the best person for the job. And the best person I ever had in an aged care role, doing lots of aged care in general practice for over 75 health assessments, was an enrolled nurse who'd worked in aged care for many, many years, which was superb with people, geriatric care. And of course, geriatric care is a bit like neonatal care, kind of ironically. It's the most complex, because by the time you're older, you've pretty much gathered everything you're going to get. There's a whole bunch of stuff. So you take a whole bunch of medications, and you've got your osteoarthritis, and you had your heart attack, and you had your gastric ulcer, and you had your bowel cancer. And now things are getting so much more complex that actually you don't just usually live with one cancer. I mean, if you're unlucky, you'll get one that doesn't knock you off immediately. But I've had people who have 3 cancers, now that the care is really getting so good. You had a breast cancer, and now you get bowel cancer as well, and then, oh gosh, then you might have something else that happens and knock you off. Well, it's a bit of bad luck, but it used to be much simpler. When the first cancer it sort of knocked you off. So I'm just saying healthcare has got much more complicated. All the more interesting for passionate people like everyone here on this panel.
Yes, just a question on how do you address GP profession burnout? I see a lot of GPs that are ground in the dirt.
Yeah, thanks for that question. Look, it's multifactorial. The RACGP Health of the Nation report from 2022 showed that 75% of GPs reported burnout symptoms in the past year. So it definitely is a problem. I think it comes down to the same things with any profession. It's work-life balance, it's control over your own environment, it's having support, it's all of those things. So some of the things we can do as a practice are we can debrief, we can have collegial learning together, all of the things that we lost in COVID, has contributed to burnout because we didn't see each other. We sat in a room on our own in full PPE, sometimes at home on telehealth, and we didn't communicate with each other and support each other in the way that we normally would. So I think that has been a big contributor. So getting back into those structures and getting out again and seeing each other has been important. There are things that the system could do to help reduce the load on GPs, the amount of form filling that is mindless and for no great purpose, or making forms more straightforward, and like those simple things which I don't think anyone really considers, the end user. So there definitely are systems things around that. I could go on. But mostly, collegiality and supporting each other and recognising that it is a real thing. We are primed to be superheroes, as doctors and nurses. We learn that early, that we are supposed to be superhuman. And some of it is really acknowledging that we're not, that we are fragile, we can break, we can be broken, and we need to be able to reach out to each other for support and not be then penalised for that.
Thank you. Is this on? I thank you all for a great deal of common sense, and I say that as someone who's was formerly married to a GP, and I'm now married to a teacher. I do find that there's a lot in common looking at it from the outside in. One of the things in common is that both professions are treated by government rather like a toothpaste tube. You squeeze it and toothpaste comes out. You squeeze it harder and more toothpaste comes out. And there is a sense that if you just keep squeezing harder and harder and harder, and you gave the example of that in the UK, how efficient is that? What I'm, as an economist, which is what I actually do, I am concerned, of course, with prices. It's very hard to attract people into a profession if there are not incomes that are remunerative, and indeed if the conditions of work are not consistent. You need a package. There's another parallel, therefore, between these two professions of health and education, I think, which is that the career paths are flattened. For teachers, it's a very flat salary scale. But I think for GPs this is also an issue. I know from my former wife, she could go and do locums in Queensland, for example. She could do locums overseas for a multiple of what she could earn even running her own general practice, which she also did. So the market rate, the going rate around the world, or elsewhere in Australia, is far, far in excess of what doctors are actually paid for the incredible skills that they have and the lifetime learning. So I'll finish on this point. As with teachers, you accumulate knowledge through life, and all of you have indicated that, and all of you have demonstrated that by your own careers. But I don't think the incentives are graduated to pay according to the knowledge that is accumulated, as opposed to the degrees and qualifications that one might earn at the outset as pieces of paper. I'm not sure how one resolves that other than by governments being more generous and probably imposing more taxes, which they should do. But anyway, I've raised a few issues there and I'd be interested in your comments. Thank you.
Tony Jones used to say, I'll take that as a comment. That's a number of comments there.
Well, there are also questions. I'm particularly concerned about this issue of career progression. If there's not a progression and an attractive package, of course it is very difficult to attract young people in. Thank you.
You're absolutely right. There is no staged career progression once you've got your fellowship, essentially, which you then are a GP, and you can do more hours or fewer hours, and that's how your pay is disproportionate to how much time you spend in front of a patient. Obviously, there are roles that you can go on and do. You could own a practice, and that may be more financially rewarding, but comes with a whole load of risk and a whole load of managerial responsibility. And Fiona might want to talk about that, because you've been there, done that, and I haven't done that here. And there are other roles that you can move into, but no, essentially it's flat, as you identified. I haven't seen anybody really want to address that.
I think that's the case in most areas of medicine. I think that you very rapidly get up to peak of your earnings, and then you start burning out. If they're surgeons, their income peaks at about 42. Because that's when they've got the stamina to keep operating all night, they're getting the referrals, and then what happens is that they burn out or they run off with, if they're a male. And they realise that they've got to get more work-life balance, but it's flat very quickly.
Could I comment on this a little bit? The structure in general practice used to be that, and this is also when I started in medicine and general practice, that you would sort of be invited to join a group of general practitioners who thought that you were like-minded and practiced as good medicine, hopefully, as they did. Right? So you'd be a reputable person and you would have similar ethos. And then you would come in and you'd buy out the person who was retiring, and that was their superannuation fund. So that's stopped essentially now. You really can hardly sell a general practice. You can sell a general practice, but it's difficult. And there's been this enormous burgeoning of the corporatisation of general practice. The difficulty with that is it's a bit like having private health insurance companies and things, is that all the money then goes to, the profits go to the owners of that. And I think the difficulty that I struggle with is that then quality and profitability are not well enough aligned. So that's one of the difficulties. So what now happens, generally speaking, is that somebody owns a practice. It might be a corporate practice or it may not be. And of course, corporates thrive because they can share, they can just have one accountant for many more people or whatever. And, just on economies of scale, it's much more efficient. And so most GPs now, they'll come to a practice and they'll say, look, I think I'd like to work here, and then what happens is you're paid a proportion. It's usually probably 60 to 65% of your Medicare billing. So in actual fact, if I got a bulk billing fee of a certain amount, which might be $40, for example, then the GP themselves gets 60%-ish of that, and the practice gets the other bit to pay all the nurses and run the practice and all that other stuff. Of course, that's why the corporates can do it, because they have many more GPs and they have one practice manager, and so the economies of scale really work. So that's fallen over in the last 20 years, and I think that's changed the emphasis. It concerns me greatly because my most important underlying value or notion, I suppose, is that I hope for quality care, and I hope for an effective and efficient spend of a government dollar. And I'd like to really know that we work in a health system that supports everybody somehow sort of equally. I get that it's not completely equal, but it is not right that people who have no money, can't access healthcare, and that's what's happening at the moment. And with the cost of living crisis on top of this other situation, it's becoming more and more difficult. I had a person just say to me today, do I have to pay for that X-ray? How much will it cost? People didn't used to say that sort of thing as much. It's happening in the last few weeks, happening more and more. Will I have an MRI, will I have a CT? Well, the CTs, we could probably bulk bill. The MRI you have to pay for by yourself because a specialist can get a bulk billed MRI, but a GP can't. And maybe an MRI isn't really required anyway. So I think there's changes all over the place, and there's efficiencies all over the place that we can make, and maybe some of those efficiencies are like, compelling me to prescribe the cheapest medication that will do the trick, and then giving me some feedback about that. Hey, great job, really good job. Maybe you can have some extra bonus because you're working so hard at not doing too many X-rays, and not doing too many CTs, and not doing too many other things. So the other comment I wanted to make is just generally about crisis, and I guess lots of things have popped up because of the pandemic, and there's been a lot of opportunities, like you mentioned earlier, Michelle, and I think that's true, but there's also some really dodgy things that are popping up because of this crisis, and I've seen some very unusual and strange things happening that I've never come across before that really worry me. So one of those things, I guess, and these are these unexpected consequences of situations, So people now might ring up and get scripts from instant scripts, because when you're going to buy your script at the chemist, perhaps there's a big circle on the floor in front of you that says just ring this person for the script and you get one. That person's never seen you, never going to see you. They don't know that you become a bit loopy or psychotic if the GP asks you to check your blood sugar too often, or if last time you went on that medication your blood pressure dropped, and or actually you have a migraine, and focal migraine that you should really be on the pill for. So there are all these risks and these strange things popping up in between everything else. But on the other hand, we know that we need to really embrace these technologies and really work together, hand in glove with the hospital system, with the tertiary sector. And in some cases that occurs really beautifully in the country, because they don't have all those super subspecialists out there. They'll have 3 general physicians. One actually has an interest in gastroenterology, and one in cardiology, and one in neurology, yet they're all on the general medical roster, and you might be a bit under one, but then actually you might get switched over to the next one because you had a heart attack the next day. So in some ways, like continuity and those sorts of things is really better in the country, and maybe the GPs are more embedded in the hospital systems because the GPs actually admit patients to the hospital. And some things, maybe the emergency departments these days, when the GP rings to hand over, my patient Joan, I ring and say, look, I'm worried about Joan. She looks okay, but I don't think she's okay because blah, 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 blah. And these days, we're put onto the nurse there who takes a message. So we don't get to talk to the doctor in the emergency department and hand over in that way. There's a whole bunch of little things that happen along the way. But there's a lot of opportunity for really great change, and I think we must seize the moment for those things.
I think you've got to get in there.
Can I come back? So it sounds like, Fiona, you're describing the quintuple aim of healthcare reform. You mentioned, cost, and it's so reducing. So if you're not familiar, it's reducing cost. It's improving outcomes for people. It's improving the experience of people who work within the system. It's what's the next one? Equity, which didn't used to be in there. What's the fifth one? Why have I forgotten it? Patient experience, provider experience, cost, and equity. Okay, so that's the basis on which we need to make any sort of reform or change, and we need to start actually working together across state and federal boundaries, and working together with aged care and general practice.
Well, my question is to Lionel. I'm hearing Band-Aids. Is there actually state and federally a vision, a shared vision about where you want to end up, and then work out how you might get there?
Certainly a vision from the state end. So we've
I don't think that's on.
views on. Oh, it's not, you can't hear me?
No, that's not on.
This man is a very important bureau.
So I think you're absolutely right. I mean, I think we need to have a much better integrated system, and there's been, I think, over time, too much of the, I mean, you've heard about cost shifting and all this state versus federal and all those boundary issues. There's no doubt that there's been this sense from the state, because the state spend on health is $30 billion a year. It's nearly 30% of the state budget. It's a massive issue for the state government. Federally, the costs are going up as well, and they're on the hook for increasing hospital costs as well, so they're concerned. I think we're at the point now where both governments are actually saying the solution is not to continue to drive this sense of separateness and us being different and guarding the boundaries, but the solutions are actually integrating the system to get one system and starting to invest in what creates the connections and support that happening. So I think we are at a fantastic point in time where, as a result of many of the things we've experienced, COVID, but also what we're now seeing in terms of primary care and the crisis, people are saying now that we need to find a solution which is actually overcoming those historically boundary issues. So I think there is a willingness to do that. The question is going to be how that's achieved. I think there's a few critical enablers. There's no doubt that relationships at the local level are key, at a whole range of the clinician level, but also at the system level in terms of the structures that exist. We have an issue where PHNs are the vehicle through which the Commonwealth wants to integrate primary care. PHNs don't represent all general practices at the moment, so I think we've got an issue there that we've got to overcome. And we've got to have some more levers about how we actually get those changes happening, because general practice is not one entity. It's a whole range of different types of businesses. You've heard about the corporates. You can have group practices, you can have sole GPs working in a house with a brass plate on the front. They're all very different, and how you start to see the change that we need to see implemented in a way that delivers for all of those different settings is going to be the big challenge, and we've got to work out how we achieve that. IT, I think, is a critical enabler. Relationships are a really critical enabler, and creating those connections between the two systems.
In mind that you can see as being the main driver?
I think at the moment it's being driven very much from the states, because, and you would have heard both the premiers of New South Wales and Victoria indicating they want a discussion at national cabinets, which is how we address this issue, because the states are seeing this inexorable rise in activity and cost of doing that, and saying it's not able to be fixed from our end, it's got to be fixed together. So I think there is an opportunity at the moment.
And general practice is where you save the costs, doesn't it? You increase from 6.5% to a bit more.
There's a question on the other back.
My question is to Nigel, but can I just preface by saying I'm not a GP, so perhaps I see it from a different perspective. I see the crisis as being more one of primary care. And you mentioned that Medicare goes back 50 years, but of course the design of general practice probably goes back earlier. The disease profile in our community has totally changed over that time, and the demography has totally changed. And the biggest demographic change has been the ageing of the population, and the biggest change in the disease profile has been the amount of chronic disease. Now, you've talked about doctors and nurses working together, but many of these chronic diseases require exercise physiologists, physiotherapists, social workers, psychologists, nurse educators, dietitians, and so on. And it just seems to me that we really need a total design in the way we integrate our primary care. And my question for you, Nigel, is anybody thinking about things like primary medical care homes, like Professor John Dwyer has been writing a lot about, where it's totally integrated? People are paid a salary, an adequate salary, and specialists come into the home rather than people having to go away to see the specialists in some hospital where they can't park, and so on.
Sounds very much like John Ward. The patient-centred medical home is a part of it. The question is how that's actually structured. And I was on there's a group that did a 10-year plan for general practice that was commissioned by the Commonwealth, and I was a state and territory member of that as well, and he talked about these concepts, which are really important concepts. There's no doubt that we need to head that way. The question is, how do we get there? And we do need to have the multidisciplinary team supported, no doubt about that, with general practitioners as a key part of that team. The question is whether we move to a salaried model. I think there's a debate at the moment about whether a salaried model is actually the right solution. I think there might be some testing and trialling of some of these models in different places, but we do need to move away. You're absolutely right. I mean, when fee-for-service medicine started and the MBS rebates were struck, the proportion of chronic care seen in general practice was about 10% of the total activity. It's now up over 50%. The demography absolutely has changed. We've got elderly patients with multiple chronic comorbidities who need much more care. It is very different to what it was, and a 6-minute consult is not going to cut it. And yet what's driving GPs at the moment, because of the way the MBS is structured, is more short consults rather than long consults. So we need to redirect that as well. There's a lot of debate in the Strengthening Medicare Task Force about remunerating longer consults so that GPs could spend better time with patients, more quality time with patients. So I think there's a desire to do that. A lot of the disciplines you talked about want to access MBS. There's a real reluctance to go down that path of having social workers, physiologists, all those people accessing MBS. I think we'll get to a point where in the primary care patient-centred medical home, there will be salaried staff, of the allied health staff who work within that team as it's defined, with the GP a part of it, and that relies ultimately on our patients accepting that when they come to that practice, sometimes they won't see the doctor at all. They'll actually see another member of the team. But the team will be working together and the information will be shared so that their care is high quality and able to be sustained in a different way. So that's where we need to go.
Can I just ask a question, please? It should be unsurprising to us all that we're actually facing an allied health crisis. It's a little bit like we've had a boil that's been festering and the pandemic has put a poultice on it. And it's erupting. And I want to ask, to what extent is that a policy failure? It seems to me that the people who are making policies are too far removed from the practitioners at the coalface. Certainly is the case with nursing, certainly it would be the case with education, and I know we're not talking about education tonight, but I believe that in fact practitioners have known for 10, 15 years that we've been facing a shortage. And we've waited till the pants are down and people have been hooked. What's going to happen? What are the policymakers doing? It seems to be it's education, health, and perhaps housing now. Thank you, Fiona. Other things that are good political, if the pressure's on, talk about health, talk about education, talk about housing, but don't take responsibility for the mess that we're in. And I want to know that what are the plans that the policymakers have to do it. And I'm sick and tired of hearing GPs say, I'm just a GP. Put your big girl's panties on and start to say, I'm a specialist GP, I'm a specialist nurse, and I want to know what are the GPs, professional associations doing, now that your pants are down, to actually change the situation and improve things, not only for the career opportunities for GPs and allied health professionals, but for the well-being of our community.
Yeah, look, you're not going to hear me say I'm just a GP. I'm a GP specialist, thanks very much. Look, you make excellent points. I'm not sure I have an answer for you. As you probably are aware, in terms of the colleges, we've got 2 GP colleges just demonstrating what it's like trying to manage GPs, and if any of you have tried to manage GPs in any way, shape or form, you'll probably know it's a bit like herding cats. So, we are a very diverse group of professionals. We work across all areas of Australia, and people do all sorts of different things. And so I think the colleges historically have really struggled to get the voice together in the past. I think we now, certainly in the RACGP, have some strong leadership. The previous president and now the current president are out there and advocating on behalf of GPs in a way that they haven't before. Look, I hear you about allied health. We really, you're right, that has been on the cards for a number of years, and allied health historically has had even less of a seat at the table and less of a voice than primary care doctors have. So, we do need to engage all of our primary healthcare professionals. That's not just GPs by any stretch of the imagination. That's all the nursing colleagues, and it's all of allied health as well. And it goes beyond that into social workers and everything else. But how do we get all the peaks together? And is it the peaks that need to drive it? I don't actually know whether it is the peaks that need to drive it. Do you have an opinion, Fiona?
I was very excited earlier when Nigel mentioned local people working together. And I think that's actually very powerful, because I think local people understand the demographic of the community they're attempting to serve. And I think that's just relationship building again, rather than the top-down approach. I guess the other thing that the elephant in the room for me in this discussion this evening is that there's been a big shift in terms of how healthcare is delivered to people. There's much more a sharing approach these days, than there even was when I started out in medicine. There are more women in medicine, but also people do have more discussions now with people as patients. What do you think? What do you think about this? What would you like? And negotiation, those sorts of things. So the elephant in the room for me is patient autonomy and patients being empowered to utilise current technologies and things to optimise their own health outcomes, to take their own role and responsibility in their own health outcomes. And some of the systems that have been developed, used to give a referral to a person and say, there, take that to the specialist and you organise your appointment. But nowadays I have to do the referral myself. And it's up to me to know that I've sent it and I've got a receipt that it was sent and received and that they received it. And then, so really that's not me empowering the patient, that's actually putting it all back on me again. So I think what's to empower people to access the best healthcare that they can afford, to then ask people what it is they're looking for in their life. How can we support their health to enable those things? Empowering them. And also then empowering ourselves in the same way by building relationships with patients and with the other healthcare providers. I think that's the answer. I think that's it.
We're almost out of time. In fact, we are out of time. But there's one topic which I'll use my facilitator's prerogative because I was hoping it would come up. But one thing that struck me, in the US, they have what are called, from the hospitals, they have these incredibly short lengths of stay in hospitals. When you go there, you find that what happens is that patients are discharged to what are called skilled nursing facilities, which has always amused me because presumably there are unskilled nursing facilities. But SNS or SNFs. There may be many hotels or a bit more than that, where essentially patients are out of the hospital where there's everything going on, but if all they need is a comfortable bed and someone around, then that could be a very useful thing. And in fact, I think there's a lot of patients in our hospitals who are awaiting discharge or awaiting transfer who would benefit from that sort of thing, but it requires nurses to go from just doing, sorry, I shouldn't say just, but focusing on residential aged care to being potentially facilities that are temporary care for those who can't be fully independent. Do you think there's a place for that?
100%. However, you just opened a big can of worms for me, because interestingly enough, that's what aged care is. So aged care, I have 41 residents in my home.
Yep. But they are residents there.
Correct. But still living with chronic disease. Most of them 3-4 different, chronic disease. A couple of cancers. Again, it's just as complex as a 75-year-old living in the community, essentially. However, there's legislation that comes down. There's standards I have to meet. To the point, a resident can put in a complaint, and I am not lying, to the Commission that I don't provide 3-ply toilet paper. Now that might sound funny, but that's real. I've lived that. However, on another note, my 85-year-old mother was discharged from a local hospital at 10 p.m. on a Friday night with no care coordination, no supports, a new diagnosis and actually a palliative diagnosis, and that happened at 10 p.m. on a Friday night. But there's nowhere I can complain to except the hospital that sent me a lovely letter apologising. However, they're not answerable. But I'm answerable to the fact I don't provide 3-ply toilet paper. To be honest, didn't even know it existed because I wouldn't buy it. It's probably too expensive. So, I just think that there absolutely is a place, but where is the specialist nurse going to be looked upon and supported in their decision to take care of that community. Because again, I can't do anything in my nursing home unless a GP signs off on 55 different forms to make my nursing home compliant, plus protect them, and meet the standards. It's no wonder we can't get GPs to come into aged care. Because they've got to do another week's work in the 2 hours that they're able to pop into the service. So yeah, great model, but again, I think needs to be well thought out and, engaged
if I'm thinking about it, would be very much a smaller facility in the community with GP and nursing support, where you would go for maybe 3-4 days a week, maybe.
So engage conversations and I guess systems around that for that service to be supported.
It's complex.
It's very complex.
Is it on the strengthening? No, not even on the horizon.
Yeah, that's dead. Got a great track record with microphones. It's not something that the state's looking at because if you look at the US system, it's a very different system conceptually, and we've actually looked at step-down facilities. We actually would prefer investing in hospital in the home as a step down from acute care rather than actually having another facility, because you have just another trade-off to another facility and then no. So I think from the point of view of continuity of care, we would actually want to invest more in hospital in the home using technology to support people being in their homes and cared for in that environment rather than having a step-down facility.
So we're going to finish there, and we have a superstar who's going to make some comments. Before you do, one, thank you for coming. Our next meeting on July 12th is going to be focusing on voice to Parliament. And Sean Gordon, the CEO of Wacol, and a legal expert talking about the voice to Parliament. I think that will be a very interesting discussion. In August, we've got Don Weatherburn, former head of the Bureau of Crime and Statistics. I haven't got that right. No, I think that's right. About the reality of crime. I know that sounds a funny thing, but he's got some fascinating things to say. So if you haven't been here before, which I know most of you have, but there are some new faces, go to our website, register, get on the list and tell other people. And tonight, it's been only the three of us, Robert, Roger and I, running it tonight, and we're looking for other people to help out if you want to get involved. But now, I've asked Viv to wind up. Viv Allinson, who is well known to many of you, absolute rock star of the aged care industry, and as of Monday, OAM, and well
no pressure. It's a big build-up. But wasn't that fantastic? Great discussion, and I love that never waste a good crisis. But I also picked up on something Nigel said about how we fix this through relationship. Not more forms, not more compliance. And I have to say, being in human services for 48 years, I am watching the erosion of compassion and care and genuine human contact and intervention because of the compliance and the new rules and how to set up the funding and how to run your business in GP, whereas your heart started you out for a service. And we're just seeing it erode around us. And I think as a community, particularly on that relationship piece, we must all put our minds to and our hearts to a humane solution to ensure that we have great health services, whether it is GP services, allied health services, nursing services, aged care services, whatever it is, we need to all invest in that, not just leave it to a few, because as you can see, those of us in healthcare are
well, am I allowed to say we're all a bit clapped out? A bit clapped out. And, you know, it's a tough gig because we signed up to serve with our hearts and our skill and our knowledge. But now we are pushed to compliance, like, you know, the 3-ply. You can get 4-ply toilet paper. It's often a special at Coles. You can get it. But again, in aged care, there is more compliance than you would get in an intensive care unit, and yet we're told it's somebody's home. And the question you asked about services for people needing temporary assistance and support, I know we offer a lot of respite at Maroba, and we have gymnasium, and we have allied health team, speech pathology, whole box and dice, and we're able to get people back home so they don't need to stay, and we aim to do that a lot. But I think we've had some great expertise here tonight, and we mustn't waste this crisis. And we can turn around. I love that, you know, let's not go over the cliff with the Brits. Let's make a difference and turn around. And I think the workforce issues are really, really terrifying. You know, when you think that we used to have 50% of doctors going into GP practice some years ago to only 15% now, be very afraid. Be very afraid. If you have sons and daughters that are thinking about a career, speak to them about medicine, speak to them about nursing. Nurse practitioners make a huge difference. Great to see you, Keith Drinkwater. I haven't seen you in a long time. And we are one of the beneficiaries of that pilot for nurse practitioners. And I can tell you, nurse practitioners make a real difference, particularly where you can't get regular GPs to attend and come along to our services. But again, there's things that limit what they can do. If the GP doesn't want to work with the nurse practitioner, they can't help that patient. The doctor will go away for 3 weeks, but will not allow the nurse practitioner to step in. That's scary. So I think there's lots of things, and you gave examples tonight of where there's inhibitors on doctors and nurses in the practice of what they can do. But we call it a healthcare team and a healthcare system for a reason, and that's because we're in it together. We are equal partners in this, and I'm a bit tied to hearing how important hospitals are and the people in that system, because I know how aged care gets treated, I know how often GPs get treated, as we are the second-class citizens. But let me tell you, this team here and all our nurses are holding up the health system out there in the community and in aged care and in GP practices. So let's give them all a hand. Thank you. Thank you for coming.